So we heard a lot today about devices. I'm just going to take a step back and do the everything but devices, which is what nearly every patient will be treated with. So no disclosures. The decisions we make when deciding whether to treat, and I literally mean whether to treat with anticoagulation, having nothing to do with the fancy technology stuff. So we need to think about what DVTs should be treated, what medications do we use and how do we start them, how long do we treat, and who should get extended therapy. I promise it will be just as exciting, but no sound effects. Okay, so our main sources come from the guidelines that were initially published in CHEST. The 9th edition was in 2012, and the big deficiency there was that was before the direct oral anticoagulants came out. So they needed a big update after all of the flurry of trials to treat DVT with the DOACs. That update came in 2016, and then there was a newer update in 2021. So the big basics on treatment with anticoagulation are proximal DVTs are treated, iliac femoral popliteal veins, meaning over the knee, but we will talk about below the knee. Direct oral anticoagulants are preferred. Everyone is treated for at least 3 months. And then the real discussion of figuring out what to do next is transient versus persistent risk, which used to be called, and sometimes is still called, provoked versus unprovoked. But it sort of moved into discussing whether the risk that caused the DVT is transient or persistent. The rule is there's no indication for an IVC filter if the patient can be anticoagulated. And then, as everyone has mentioned, why do we treat? So we treat for symptoms, we treat to prevent pulmonary embolism with all of those complications, and we treat to prevent post-thrombotic syndrome. So when talking about transient versus persistent risk, and these are not all of them, but these are considered to be sort of the classic low risk, medium risk, and high risk. So surgery carries a risk of recurrent venous thromboembolism of 3% at 5 years. Estrogen pregnancy, flights over 8 hours, not all exactly the same number, but roughly in this middle category, 15% risk at 5 years. And the high risk is cancer, 15% at 1 year, which probably makes sense in light of looking at all of the cases that were presented, which ended up being people who had metastatic cancer and had these extensive venous thromboembolism that needed to be addressed. So when we talk about whether to treat, so reasons not to treat with anticoagulation would be high risk of bleeding, and that takes us into the IVC filter world, which I know will be addressed in the PE talk, and then there's a separate IVC filter talk. And then the other question are people who are at lower risk of complications from the DVT, which is really this whole distal DVT question that was also mentioned earlier. And again, we treat for symptoms to reduce the risk of embolism, to reduce the risk of post-thrombotic syndrome. And this question that also came up, should distal calf veins be imaged routinely? So actually in the guidelines, the answer is not necessarily. The protocol in our lab is that we do image below the knee, and the reason for it is really this question of progression to a more proximal DVT. So the biggest randomized trial looking at isolated calf DVTs was published in JAMA Surgery in 2016. So interestingly and importantly, this trial preceded the DOACs. And looking at 384 patients that were randomized, they saw anticoagulating decrease the risk for a proximal DVT or PE at 180 days. But the odds ratio is super low at 0.34. And these patients did have a big increased risk for bleeding. And so the authors concluded this needs to be a very individualized decision of whether the patient would benefit offsetting the risk of bleeding. I should add 75% of these patients were treated with warfarin and most of the rest with Lovenox. So it's a little bit of a different world. The guidelines for the isolated calf DVT are if you have severe symptoms, if there's a risk for extension, you treat. If you don't, you can either choose to watch it with serial imaging. So the 2016 update was you treat for 3 months, you would not treat a distal DVT longer. The 2021 update was serial imaging means you do an ultrasound weekly for at least 2 weeks. What ends up happening in real life is there are patients who don't really want to come in and get a serial ultrasound every week for a few weeks, and sometimes you say it might just be easier and safer to treat. What about superficial vein clots? I know, we're talking deep, but the risk of some of superficial clots, especially with an extensive superficial burden, is 8 to 10% or so, can progress to a deep vein clot. And so there were 2 major trials that looked at treating SVT to prevent DVT. The first was Callisto, published in the New England Journal in 2010. They looked at fondaparinux, which is a sub-Q injection every day, and they saw that doing those injections for 45 days significantly lowered the risk of death, DVT, PE. 7 years later, published in Lancet Hematology, there was a non-inferiority study looking at rivaroxaban or Xarelto, which was found to be non-inferior. And that has taken over the field because nearly everyone would say, I'll take a pill for 45 days rather than give myself a sub-Q shot. Okay, so the big medications. There's 4 major anticoagulants that have all been studied, all published in the New England Journal, but the way we choose among them are really the nuances between. So of the 4, 2 have to be pre-treated with IV heparin. So that's dabigatran on the top, edoxaban on the bottom. And it makes sense from the perspective of, in the warfarin era, everyone was treated with heparin first, so when these trials were designed, that wasn't considered a limitation. But nowadays, you have apixaban and rivaroxaban that can be fully treated at home. The other big difference is kidney function, where edoxaban has a renal dose. Everything else you can treat down to a creatinine clearance of 30. And then the big question is recurrent clot versus bleeding. So if you look at the top one, dabigatran, pretty similar recurrent risk of clot, less bleeding than warfarin. Rivaroxaban, great improvement in recurrence, same thing on bleeding. Apixaban, a little bit of a better prevention of recurrence, significant decreased risk of bleeding. And then edoxaban, big improvement, bleeding not that much better. And so when we make the decision, what you end up looking is at each individual patient, their risk of bleeding, their risk of recurrence. Special cases that I'll just mention briefly, antiphospholipid antibody with DVT, we use warfarin. Cancer, I'll actually go into on the next slide. Renal disease, we mentioned, and obesity is a big one. So 3 trials were studied in the use and the treatment of DVT in cancer, all compared to dalteparin, and I should mention the rivaroxaban one was retrospective. All prevented recurrent DVT or PE. However, only apixaban was equivalent on bleeding, and as a result of that, the American Society of Clinical Oncology favors apixaban if you're going to use an oral anticoagulant. The other 2 just have too much bleeding. Obesity is a hot topic everywhere. The International Society of Thrombosis and Hemostasis addressed this. If you look at the trials of the oral anticoagulants, most did not use patients with a BMI above 35, only rivaroxaban. And then in the post-marketing data, we have data on apixaban and rivaroxaban. So the rule is you can use any of them up to a BMI of 40. When you get above 40, you should really use either apixaban or rivaroxaban. Rivaroxaban has more data. Post-bariatric surgery, which is another hot topic, there's probably an effect of absorption on all of the oral anticoagulants. Apixaban is probably the safest, but most people will choose between that or low molecular weight heparin. So how long do we treat? So going back to that little table from earlier, you need to think about the risk for recurrence, provoked, and transient. So everyone is treated for at least 3 months, and then the decision is whether to extend therapy. So one of the things that we do in deciding whether to continue anticoagulation is we use D-dimer and factor VIII. So this goes back to a paper published in the New England Journal over 20 years ago, where this group looked at factor VIII, and not a factor VIII level that comes out red in my chart, but above the 90th percentile, so a high factor VIII level, and found that that correlates with your risk for recurrence. So significant recurrence for patients with a high factor VIII. These were patients where anticoagulation was stopped, and factor VIII was measured 30 days off of anticoagulation. And then the update on this was an Italian group published in 2008, where they took the 2 biomarkers that are considered most predictive, D-dimer and factor VIII, measured them in everybody, and they found that the group that had a low D-dimer and a low factor VIII had a low risk for recurrence out to 2 years. When both were high, a much higher risk. I should also add they used a factor VIII cutoff of the 75th percentile. We use 90th. And then finally, the 2 major oral anticoagulants that we use, apixaban and rivaroxaban, both were studied in a similar kind of design of patients who were treated for 6 to 12 months. Is there any benefit in continuing therapy? And both trials looked at 2 different doses, apixaban versus placebo, rivaroxaban versus aspirin, and found that continuing therapy lowered the risk of a recurrent event for both. and that the risks of bleeding were similar. Just interesting to note that apixaban had a similar bleeding risk to nothing, and rivaroxaban had a similar bleeding risk to aspirin, which does have some bleeding risk. And so these are good options for when maybe there's hesitation or you feel unsure about whether the patient is safe to stop anticoagulation. You can do these continued therapies and then reassess. And that's it. Thank you.